Good afternoon and welcome to the Alliance for Home Health Quality and Innovations webinar on Progressing Together, the next phase of the Home Health Quality Improvement Campaign. My name is Teresa Lee and I'm the Executive Director of the Alliance for Home Health Quality and Innovation. As you may know, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value home health care has to offer to patients and the entire U.S. healthcare system. Today's webinar is part of the Alliance's Learning Collaborative series. These series of webinars seek to offer information and perspective to help home health providers navigate healthcare delivery system change and reform. Today's webinar will focus on the fourth phase of the Home Health Quality Improvement Campaign. Although many of you have been involved with HHQI for some time, this is an excellent opportunity for all of us to learn about critical new developments in this new phase of the campaign. We're fortunate today to have as our esteemed guest speakers Cindy Sun and Misty Kevich. Cindy Sun is the lead cardiovascular project coordinator for Quality Insights, the Medicare Quality Innovation Network Quality Improvement Organization for West Virginia, Pennsylvania, Delaware, New Jersey, and Louisiana, supporting the Home Health Quality Improvement National Campaign under contract with CMS. Cindy is a family nurse practitioner with experience in a variety of healthcare settings, including home health, hospitals, and physician offices. Her responsibilities with HHQI include coordinating more than 170 national network coordinators, developing educational resources and data reports, as well as being a primary resource for the nation's home health agencies. Her newest responsibility is leading the integration and evaluation of preventive cardiovascular care into the home health setting through the Home Health Cardiovascular Data Registry. Misty Kevich is an RN project coordinator for Quality Insights. She primarily works on the educational aspects of the HHQI national campaign. This involves researching and writing content for the best practice intervention packages, or BPIPs, and supporting materials, as well as supporting underserved populations. She will be leading the new HHQI University platform for education, as well as continuing education credits. Just a few housekeeping notes before we get started. First, Cindy and Misty will present for approximately 40 minutes and will leave the last 15 minutes for discussion and Q&A. Please note that this is a webinar and we control the slides on our end, so don't be surprised if you cannot flip ahead. Second, your lines will be on mute, but please do submit questions through the Fuse webinar software on your computers or other devices during and after the presentation. You can send a question to the speaker by sending a question to me, Teresa Lee. Finally, we will be posting the slides on the members only portion of the website after this webinar. We are also recording the webinar and will post the playback on the website. And without further ado, I'm going to turn this over to Cindy Sun for her to start her presentation.
Thanks, Teresa, and hello, everyone. And we want to thank you for the opportunity to share with you what's going on not only in home health but in HHQI. So we'll start with just talking about what is HHQI, and I know that many of you are familiar with HHQI, the Home Health Quality Improvement National Campaign, and some of you may have never heard of it. So just to kind of get everybody on the same playing field, if you will, we'll just let you know that HHQI, it's a CMS, which is Center for Medicare and Medicaid Service, funded special project that's focusing on the prevention of avoidable hospitalizations by providing free evidence-based tools and resources, and this dates back to 2007. I only mention that as some of you may have participated 5 or 6 years ago and maybe lost touch with it, just to let you know this is the same project. Now, it's also important to note that being a CMS-funded project means that all the resources are public domain, and that means that everything is free of charge, free of obligation, and almost completely free of copyrights. The only reason I mention almost is because there are 2 or 3 tools that are validation tools that you might find on the website, and there'll be a large copyright logo on there. The only reason is because they are validated. As an example, the Morosky scale, the medication adherence scale. If you're not already using it, it's available on the website. That's a scale that if you alter the language and edit it in any way, you'll lose the validation. But otherwise, it's totally free to use in your agency. Now, one of the key enhancements that we talk about in HHQI, there we go, is as Teresa was mentioning, that we'll be talking about those throughout this time, but we talk about the cardiovascular integration of preventative care in the campaign. Now, everything in HHQI, it's a virtual campaign, and it's located, what we call our office, at www.homehealthquality.org. And when we're talking cardiovascular disease, one of the important factors is, I think that we all get so many statistics thrown at us, and I hate to throw more, but just to bring it to the forefront, heart disease and stroke, number 1 and number 4 causes of death in this country, and 1 out of 3 deaths in the United States is related to cardiovascular disease. The biggest thing, well, maybe not the biggest, but something that's very important also, cardiovascular disease is the greatest contributor to racial disparity in life expectancy. And if you're not familiar with those statistics, have a look at the underserved best practice package as well as the cardiovascular best practice packages, which we'll talk about in a little bit. And you can see the extent of the racial disparity. It's monumental. So when we're talking about cardiovascular care in the home, we're usually talking about the patient on the right who has the oxygen, bed-bound, exacerbation of heart failure or exacerbation of cardiovascular disease. But when we want to talk about the patient on the left, what about the patient who may be seen in the agency for, maybe they had an orthopedic procedure and they're being seen for therapy, or maybe they have a GI or abdominal surgery, but they also have an underlying cardiovascular disease. If that patient returns to the hospital, it still counts against the home health agency as far as numbers. Let's not even mention the fact the quality of life on the patient. So that's where all of this preventative cardiovascular care and the integration of it coming into the home health setting, that's kind of where it's stemming from. Now, the Cardiovascular Improvement Initiative, it does align with the Million Hearts Initiative. And if you're not familiar with the Million Hearts Initiative, that is the one that Health and Human Services is the kind of what we call the big dogs of Health and Human Services, which would be CMS and CDC, the Centers for Disease Control, are the co-leads on Million Hearts Initiative. And the focus there is to reduce by 1 million heart attacks and strokes by 2017 using the ABCS model. A is for aspirin is appropriate, blood pressure control, cholesterol management, and smoking cessation. Now, to talk a little bit more about the tools and resources that are available through HHQI to integrate the cardiovascular prevention in the home, I'll turn this over to Misty Cavich. Misty?
Thank you so much, Teresa and Cindy. We're one of the big focuses and our cornerstone of HHQI has been our education, and we will be providing it throughout this 4th phase in a variety of formats. And I'm going to touch on the primary and focus BPIPs, and I'll explain what those are in a minute, as well as video, courses, continuing ed, and Spanish translations. So let's get started. First, who's our audience with the materials that we have provided on HHQI? Really, it is really pretty much for everyone. It is for leadership. When I talk about the packages, I'll tell you a little bit more about that. For nursing, for therapy, as well as social workers and aides, that we even include material that can be used for aid education, knowing that they require 12 hours in a year for their education courses. But it also includes patient and family education tools and resources. So let's take a look. We have several types of BPIPs, which are best practice intervention packages, and they are, primaries are larger packages. They are more comprehensive. They have the full parts of the evidence-based practices. It has lots of tools and resources. Focus best practice packages, which were last phase, we introduced those. They're shorter with key resources and tools. The video BPIPs are something new. I have a slide. We'll talk about those. They're coming spring of 2015, as well as online educational courses. And these are going to come through beginning in 2015 as well. So let me see if I can get us caught back up to our slides. And we'll dive right back into the cardiovascular packages, the primaries. In the third scope of work last year, as Cindy kind of already laid out some of the statistics, just some key statistics on how much cardiovascular health impacts our healthcare industry. Cardiovascular health has become a very important focus for Medicare, which is CMS, and we have joined working on the Million Hearts campaign, as Cindy talked about, or at least supporting it. And the way we have done that is created a true best practice package. Part one is on aspirin and blood pressure. They're primary, they're larger. And then the second one was cholesterol management and smoking cessation. And those were packages to provide the basic education related to those types of patients that we can do. Assessments, teaching, a lot of lifestyle modifications will impact those patients' risk. We posted those last August and last November. And of course, as things go, the end of November and the beginning of December, new guidelines came out for blood pressure and cholesterol management, which we had been waiting for all year, especially for the blood pressure. So we did release what we called our updates to update those key evidence-based practices to complement the key best practice packages. So there are 4 references. What I will tell you is ideally what we have done starting in December the 1st. If you've not downloaded those packages, we are going to be combining those. So there will be just 2 packages, the aspirin and blood pressure, as well as the cholesterol management and the smoking cessation. So it'll be easier. We've integrated all of that into those same best practice packages. Okay. And when I talk about the focused best practice packages, we have posted those on things such as heart failure, disease management, where it's giving you a smaller amount, the key information, very targeted information. So with that, those are the types of best practice packages that we have provided. And our new type of best practice package is the video BPIP. We know that video is a great way for those adult learners that are very visual and again, a different approach in providing the education. So we're going to be starting in 2015 in the spring, having professionally produced short videos. They'll be clinician-focused as well as patient-focused. And the other good news is that there will be English and Spanish versions, so at least there'll be a Spanish translation that will be available. The intent is so that clinicians can use the information and learn how to integrate that into day-to-day home health practices, and they can use the patient-focused videos as part of their education, either on a tablet, on a laptop, or even on their smartphones. And they'll be able to be downloaded. So if you're not in an area that is able to support those rural areas that we have difficulty with, then you're able to still use those. There'll be 5 to 10 minutes basically for patient videos, and about 10 minutes for the videos for the clinicians. And this year they will be focused heavily on cardiovascular health. So it'll include things such as lifestyle management, smoking cessation, and also with blood pressure management and things like that. So it will be very relevant topics that will be applicable to all of your population that you're addressing, even those knees and hips, just to make sure that we're reaching out and trying to address their quality of life. Now, what else is new in this 4th phase that we're very excited about is the HHQI University. And it's going to be a platform for learning and really trying to engage not just leadership to come and learn, but your clinicians. And this is a free, easy way for clinicians to come on and receive education related to the topics. They'll be able, it's a very icon-driven, very simple to use. They'll sign up one time, then they'll have access to enroll themselves into educational courses. There'll be at least one new course every month that will be provided, and I'll talk about continuing ed on the next couple of slides. But again, it is a way for leadership to make it very easy for your clinicians to get the materials either during a staff meeting, if you have them assign it to them to do on their own, but it's a way that we can get the material out very timely, not pulling them from their patients and coming into the office. So that is kind of where we are going with the university. The content will include those evidence-based practices that were included in the BPIPs, that our material, as well as any new or significant resources that are out there. We'll talk about a key tool or resources so that they can see and be able to find something that may work for some of their patients. They'll be using a multimedia. Sometimes it'll be podcasts that they'll listen to, and there'll be some reading. There'll always be an evaluation and a post-test, and a certificate will be automatically generated once they've completed the course. They can stop and start a course as their time permits, and their certificates, if they need to go back because they didn't print it out or they didn't save it electronically, they would have access to looking at all of their certificates that they've achieved. With that, the reason certificates are so important is we're going to be providing free nursing continuing education with many of our e-learning courses. The reason we selected nursing first, it is the largest discipline that is out providing care to our patients, and it is so it is a very good starting point. We'll talk about therapists here in just a minute. So our nursing CEs are going to be available on some of the courses, but it'll be designated that way. Beginning early in 2015, they will be approved by the American Nurses Credentialing Center, so they are very applicable in almost every state. A few states have some specifics, but they do accept those. It's just you have to have a limited number of outside of your state venues. So if you have any question, do check your board, but if not, contact us. We'll be very happy to show you what we're able to show you that your state will and do accept those. Now, a lot of our education is truly geared for all disciplines, PTs, OTs, and even speech-language pathologists. I'll talk about social workers here in just a second. We know that the material is relevant. We really try to pull that through, and we'll continue to pull more of how it applies into those therapy disciplines. We are not going to be able to provide CEs for the therapist for all of the sessions. We are going to try to do a few sessions that way. The issues are with the physical therapist primarily because they do not have a nationally accredited certification process that states accept. It's really based upon individual states, and their national association, the APTA, does not have something that is recognized either. So that creates a big problem to try to get 50 states and 3 territories for continuing ed. So we will can continue to work with the APTA on that. Now the AOTA and the ASHA for social workers, they do allow you from a national perspective, and a lot of states do allow you to have additional certificates from outside sources. So even for the PTs, they may be able to use the certificates that they will receive. We do gear tracks and information towards social workers and home health aides to provide them education. They would get a certificate for participating. We will look at also perhaps having a couple social worker sessions in this phase as well that they would be able to get continuing ed. So, and as the BPIPs are released, we'll continue with having CEs related to those. Patient education, we really have a lot of key tools and resources. We look at health literacy. When we create, all of our tools that we create are always health literate. A lot of times we've tapped into the CDC or other organizations, and maybe the font size isn't the best, or it's not really at a fifth grade level. So we're really being very careful on the resources that we provide, or we will recreate resources, again, making sure that they're very health literate at that fifth grade with the white space, etc. The other piece that we're very excited about is Spanish translations. We have heard for years and years, we need this in Spanish, we need this in other languages as well. What we have been able to do in the Phase 4 is to do Spanish translations for many of the key tools and patient resources, even tools and resources that were released in Phase 2 and 3 but are significant and still current and up to date. So if you're not already signed up for HHQI, please do so. And do sign up for the e-newsletter that comes out monthly. It just came out last week, and it provided a link to 6 resources. Some of our most popular resources were included in those first 6 that are now translated in Spanish, and there were links to both English and Spanish there. And the patient videos will also be have Spanish translation available with those. Now, things are looking up. This slide is referencing to our Underserved Population Network, or UPS as we call it. Underserved population became very important and written into our contract for the 3rd phase of HHQI. And because healthcare all over in every setting is really starting to focus in on population health and looking at the underserved, we know the largest amount of our healthcare dollars are going for the top 5% of our patients that are the higher spenders, and they are typically the dually eligible, or those that live in poverty areas or have a lot of health disparities, such as health literacy and things that we've talked about. Cindy mentioned earlier that the underserved population BPIP, that best practice package, we released February of the year before last, I guess, so it's 2013. It is a large primary BPIP filled with tons of resources and information related to the underserved populations, related to underserved regions, looking at health disparities such as literacy, socioeconomics, race, and culture. Also looking at the dually eligible. And another one of our focus areas is small home health agencies, and many of you on this call today may be a small home health agency. You've limited supplies and resources. So not only did we create a best practice package for you to work with or use it as a resource, but we also created a plethora of wonderful underserved population webinars, and they're under our UP tab, under the archives, and there's everything related to race and culture, compulsive hoarding, medication management, working cross settings, just it goes on and on. Look through the archives, find something. They're typically 60 minutes. You can listen to the recording. Great insight from key leaders across the nation. We also have relevant data that's in our HHQI data reports that Cindy's going to talk about here in just a minute. So with the underserved population, this is continuing in Phase 4. We will do our update newsletter, e-newsletter, will come out quarterly beginning in December. So make sure you sign up for that. It gives you some relevant studies that are going on, some key resources, kind of brief, but really trying to keep the focus of the underserved within a newsletter. And we will be doing our UP webinars. They'll continue, but only quarterly this time. And the first one will be coming up in January. So you'll hear more about that over the next month or two within the e-newsletters and the information on HHQI. So with that, I'm going to transition right into Cindy to talk about the data.
Thanks, Misty. And yeah, when we're talking about data, I know some of you out there are probably not, data is kind of a 4-letter word, and I understand that. It's not a nice word to some people, but the thing is, data-driven quality improvement is a must. And by looking at the most recent COP, or at least the suggested COP that is out there right now, data cannot be more relevant. So what we want to talk on just for a second or two here about data reports that are available to every single home health agency, every single CMS reporting home health agency has 3 data sites that really, if you're not already doing it, you'll want to be kind of eyeballing them at least once a month just to know what CMS is seeing about your agency. Even if you have a vendor and you have that love, that's a privilege and a wonderful idea. But even if you don't, the data sites are there. So the first one, of course, is Casper, which most of you probably are already familiar with. And Casper is a report, the data source is the OASIS, and it provides, I'm going to reuse Misty's word because it was great, plethora, an abundance of outcome and process measure reports that are available so that you can see what is being, if your agency is kind of progressing the way you think it should. The second site every CMS reporting agency should be eyeballing at least monthly is Home Health Compare. Now, most of you are probably familiar with it because that's also reporting the HCAHPS, and it's showing the public, which are both your referral sources as well as your patients and their families, what they can see about your agency. Most of that data comes from the OASIS. Of course, the hospitalization rate and the ED visits are coming from your claims data. And that is all risk adjusted, and that's why it's publicly reported. The third site are the HHQI data reports. Whether you want them or not, all 12,000 home health agencies in the country have 5 unique reports that are waiting for you. If your agency has been reporting since 2009, you will see data dating back to 2009. And these are what the reports look like. The first page, they go on for about 8 to 10 pages each. They cover acute care hospitalization reduction. That's delving into not only the ACH rate, but it's also looking at your risk-adjusted rate, what percentile your agency is in compared to the rest of the nation, and also how you are comparing to the rest of the agencies in your state. In addition to that, it talks about, as Misty was mentioning, the disparities in care. Does your agency have a disparity in care when it comes to ACH reduction? Is a particular race or a particular payment source or maybe even a particular age group as a higher ability to go back to the hospital? What day of the week are most of your patients being admitted? And for what cause? Have a look at it if you haven't. And again, this is to help guide. These are just tools to help guide your quality improvement performance. As far as if you're looking at the day of the week and you find that a lot of facilities that are in what we call snowbird regions, whether you're receiving a large population or a large amount of your population is dispersing through certain seasons, have a look and see if that impacts your rates. And then see if that's transferable, if you want it to be transferable to the other seasons of the year. The other thing is what day of the week. And by that, you can focus in on your unique community. See if there's something that's going on in your community that is causing the patients to remain out of the hospital on certain days, and if there is a way to transfer that. I don't know who's on the webinar right now, but we've heard from actually quite a few agencies that were in Florida and California where a lot of families would come to visit, and they found that their patients were staying out of the hospital while the families came to visit for vacation, but as soon as the families left, that's when they were being admitted. So they looked into it a little deeper and were able to go and find that that was kind of a correlating factor between all of them, and they were able to use that information to improve the quality of care that they provided to try to prevent those patients from going to the hospital, to see if there was something going on that they were missing or possibly eating, if they're heart failure, to see if they could help with that, and they did see improvement. So I just want to mention that these reports are available. So they're looking at ACH, oral medication management. Your immunization reports are both flu and pneumococcal. And then you also have a cardiovascular risk report. Again, all of these reports come directly from the OASIS information. Now, as we all know, anybody that completes OASIS information, as great as the OASIS is, it doesn't really capture a lot of cardiovascular information. And so for that reason, as you are beginning to implement or you want to see where your agency stands when we're talking about the ABCSs of cardiovascular care, the Cardiovascular Data Registry, or HHCDR as we call it, has been created for this reason. A few of the details. In order to access the registry, you go through the normal HHQI data access portal. Now, the registry itself will be a hybrid approach. It will have most of the demographic information from your OASIS embedded on each patient. But what it will require is a few extra questions to be answered by your agency on certain patients. It doesn't have to be on every patient, but on 12 patients per measure, and I'll get to that in just a minute. The pre-populated information will go on the 15th of the month, and we're very happy to say that that's going to start this month. That's going to start over the weekend. Yeah, we know it's a weekend, but we wanted to keep it on the 15th so everybody was aware of it. Then for all the agencies who have completed their information and what we call close out their month by the 14th, let's just say December 14th, then about a week and a half later, around the 23rd of the month, you'll have a report indicating how your agency is doing. When we're talking about the ABCSs, we already talked about what they stood for, but these are the types of questions that you'll be asked based on, in the registry itself, based on this. If you choose to participate, I want you to see that it's very simple. If you choose to focus on aspirin usage, meaning is the patient following the physician's plan of care? Should they be on an aspirin or antiplatelet? The question you'll be asked, pretty difficult. Was the patient taking aspirin or other antithrombotic? It's a yes or no question, and that's it. Now, let's say you chose to focus in on blood pressure, and the blood pressure question will only be populated for patients who have a diagnosis of hypertension. So the question is, what was their final blood pressure before being discharged? And was hypertension addressed during their episode of care? And that's it. The extra question, if you choose to focus in on cholesterol, and again, this will only be asked for patients who have ischemic vascular disease, the same as aspirin. And if you're not familiar with ischemic vascular disease, it's a large group of diseases that basically prevents anything that's preventing oxygenated blood from getting to the tissue. So if a patient had a heart attack, or if a patient has had a stroke, or maybe they have peripheral artery disease, and there's probably about 100 other diagnoses in there. If any of those are on your OASIS that you transmitted to CMS, it will show and they'll populate with the cholesterol question. That's only if you select cholesterol, and the question is, did the patient have a lipid screening in the past year? And if so, what was their LDL-C? And if you choose to focus in on smoking, especially for those of you that are focusing on wound care, this is huge. The question you'll get, because we're looking at tobacco use, not just smoking, simply, was the patient screened for tobacco use? And if they were found to be a user, was an intervention implemented? Now, if you're not familiar with all the resources, it's overwhelming how many and how wonderful the resources now are out there for clinicians in the home, as Misty was talking about. The cardiovascular Part 2 best practice package is just full of resources for the clinicians. It's turnkey. They are electronic, they are paper, they're streaming. And again, I'm repeating what Misty said, but I'd like to make sure that we leave this webinar today with you understanding this is a huge improvement over care that has been provided over the past number of years. Or I shouldn't say care that's been provided, but the resources that have been provided to clinicians. And no, they're not just for in the home, but they're perfect for in the home. You know, in home health, we have a unique setting. And Misty and I don't know if we mentioned, but we're all home healthers ourselves. Home health gives the opportunity for us to be able to reach the patients in a setting that is unlike any other. And this is something that we need to take advantage of in home health. This is an area that, even though they may receive the exact same information in a hospital when the patient's being discharged, or in that 15-minute window when they're seeing the physician in the physician's office and they have white coat syndrome, the place they're most likely to absorb it or to grasp the information or to actually what we call hear it is going to be in the home. And it's going to be with that clinician who has been coming to their home, who knows them, who knows their animal or dog or cat's name. They're going to hear you. Whereas in other healthcare settings, although the clinicians may be equally wonderful and doing everything the exact same way, the patient is not usually in the place to where they're going to hear this information. So we'd like you to take advantage of being in the home and utilize these resources because they're from all different resources, not just HHQI. They're from American Heart Association, American College of Cardiology, the American Lung Association. All of these are on here, so all you have to do is one-stop shopping, and you're free to download them or use them as you see fit. And as a clinician, I'm an old clinician. Oh, I would have loved to have had these when I was in the home. When I did 3 minutes of smoking counseling in the home, it was usually me just talking. I had very limited resources, or I had an old black and white trifold pamphlet with lots of text on it. That's not the case anymore. Now there are, as you're sitting doing your charting in the home, the patient can be watching a 3-minute video or a vignette. Or there are some that are just the vignette itself where the clinician can talk over top of it. There's no audio. There's multiple options there. So in addition to having the data registry and the best practice intervention packages to help support the integration of preventative cardiovascular care, HHQI has created the Cardio LAN, or the Learning Action Network. And this is just simply a group of people, if you want to call it, who come together once a month for a teleconference or a webinar, and we'll be discussing different types of cardiovascular care, whether it is, most of it will focus on home health, but it will also be care that crosses care settings. We'll have different presentations on a monthly basis, and we'll be talking a little bit about the registry, but primarily we're going to talk about different types of information that will translate to all types of patients. Even if you are not participating in the registry, we want to encourage you to take this opportunity, network with others, share your resources. This is going to be a group who are going through the same thing, because preventative cardiovascular care in the home is rather a new concept. So we wanted to have this as an opportunity. The first meeting of the Cardiovascular LAN will be on, it's always going to be the third Thursday of the month at 2 o'clock Eastern. In order to help with this and to help with the moving through the cardiovascular implementation, you'll be receiving what we call cardio milestones, and you can see by reading here. You'll receive a logo and a designated certificate for each of the stages or each of the milestones that you accomplish as your agency goes through the process. To access any of this information, this is the HHQI website. You would just hover over the Cardiovascular Health tab on the blue toolbar, and it takes you to the page where you can click the blue button that says Join Now. All you're joining is to receive information once a month to let you know what's going on with the Cardio LAN. So we want to encourage you to do that, and that's not just for those who are participating in the registry, as I mentioned. That's for everyone. And by clicking this, your agency you'll see the interactive map at the bottom of the page. When anyone comes to this map, and I mean anyone, this is open to the public, they'll click on any of the states. It will populate a list of agencies who are participating in cardiovascular health movement. We understand that this is being used by referral sources because we've taken the call where agencies have panicked and saying, okay, we've got a call. We're supposed to be on a map somewhere on your site. Our agency's not listed. How do we get there? This is how you get there. Click the blue button that says Join, and you're automatically joined. From that moment on, your agency will be listed as going through the cardiovascular process. Now, in addition to this, we also have networking opportunities that go beyond cardiovascular. There's multiple virtual as well as grassroots options through Facebook, Twitter, the social media, LinkedIn, YouTube. We also have what we call online sharing resources, which will include the HHQI live chats. Those are once a month. If you haven't participated in any of those, they're actually kind of entertaining. No audio, just straight visual. It's actually a chat room. And you have live access to not only the HHQI team, but to each other. What other opportunity do you have to be anonymous and come into a chat room to talk about home health? And it's live, so everybody's going back and forth, and it's actually quite fun. The chats are archived. You can look on the website and have a look at what other content's been covered. The HHQI crew is there if there's anything that we can answer, but there's also, like I said, it's a full hour of opportunity to talk with each other. Now, in addition to this, we also have the network coordinators, as Teresa is one of the network coordinators representing the Alliance for Home Health Quality Innovation. This is an area where each state has representation by the network coordinators, our home health associations. They are corporate agency leads, they are consultants, some of them are vendors. We welcome everyone to be a network coordinator. This is someone who has access to multiple agencies who will be kind of a representative, if you will, in HHQI, and they will keep you abreast with what is going on in home health and HHQI. In addition to the list that I just made, you'll also have what we call the Quality Innovation Network Quality Improvement Organizations, or the QINQUOs. These are the folks representing your state, and they were called until the middle of the summer here your QIO, your Quality Innovation, or excuse me, your Quality Improvement Organization. Well, that whole process has changed, and that's what I'll just take a second to talk about here. The QIOs, if you remember back before July, every state had a QIO, and there were basically 47 or 48 QIOs in the country. On August 1st of this year, they basically melded into 14 QINs, or QINs as we call them. The QINs are now representing, as I said, 14 different regions, and you can see by the map that the regions are outlined in color. And for a list of who is representing your state, there is a list on the HHQI website under the About Us tab and under the Network Coordinators. And if you can't find it, we'll give you our email here. We'll be glad to get you in touch with them. The reason for that is the collaborative effort that is going on with home health coming back into the QIO work, or the QIN QIO work. This is a brand new thing. This is something that you all have asked for as agencies for years. If you remember back, if you were participating in home health back in 2007, that was a time when the QIOs were working with agencies and home health was part of the national work. Well, starting August of this year, it's back. The thing is, every agency is welcome to participate, but there is a finite number that some of these states will be working with. It's different across the country. So what we'd like to do is encourage you to take this opportunity and contact the person who is leading your QIN, QIO in your state and find out what they're doing with home health and see if it fits into your scope of work. This will be for the next 5 years, and this is one of the greatest opportunities that all home health has had. So we want to encourage you to take advantage of it. HHQI is going to be here. We're here. We're going to continue to work with agencies all the time, as we always have. But in addition to this, now you have a resource in your own state that can lead you through this or help you with your quality improvement. There's no obligations, there's no rules or regulations or anything like that, but it is an opportunity to have a quality improvement expert in your state work with your agency directly. So with that, I wanted to mention our website again and how to get a hold of us. Misty and I are both at HHQI at WVMI.org, and we'd like to encourage you to reach out to us and let us know what we can do to help you and what we can do to help the agencies in your state. So, Teresa, with that, I will turn it back to you.
Okay, terrific. Thank you so much. I really think that you guys did such a comprehensive job of providing an overview of some of the really significant changes, not the least of which I think is this shift toward, the individual QIN, QIOs. I know there's sort of an alphabet soup here, but to have those individual QIN, QIOs assigned by geography to helping specific home health agencies, I think that's a really huge change. And just the fact that home health agencies are going to have to sign up, and it sounds like the message, please clarify if I'm wrong, but it sounds like the message is some of these QIN, QIOs who can help individual agencies have caps on the number of agencies they can help. So if you want to get help, you need to sign up as soon as possible in order to make sure that you're included. Is that right?
It is correct. It's not the same for every state. Some states are allowed to take every agency total, but some states do have limited resources, and they have a cap of how many they'll be able to accept, and it's not based on anything else. It is not based on your ACH rates. These are the questions we've been receiving in HHQI. It is not based on your geography. It doesn't matter if you're actually inside of a community or not. It doesn't matter if you've worked with the QIO before or not. Every home health agency is welcome to participate. But yes, you're correct, Teresa. Some of the states do have caps, and we are already anticipating the heartbreak that we're going to be experiencing ourselves when we hear the stories 6 to 7 months from now from agencies who weren't able to get in. And that's what we're trying to prevent from happening. So get everybody in as fast as you can, at least hear about it, to see if it's something that you're interested in doing.
Right. And just so that I've got a sense of the kind of help that the QIN, QIOs are going to be able to provide. So let's take, for example, the new conditions of participation, which I recognize are just in proposed form right now, but ultimately some form or fashion will likely get finalized. Will the QIN, QIOs be able to help a given agency make sure that they're in compliance with the COPs, for example?
Cindy, this is Miss.
Oh, sure. Go ahead, Misty.
I'll jump in first, and just to let you know that the COPs really directly align with the HHQI work, and also what the QINs or QIOs are working on as well. If you even read the preamble, our resources are referenced numerous times. The talk about the underserved population is also referenced. But QINs, that were formerly, QIOs, all these acronyms, but they're specialists with quality improvement. And when you look at the conditions of the proposed conditions of participation, it is every agency is going to have to develop a couple QAPI plans. You've got to do one on a measure that you're allowed to select yourself and an infection control QAPI plan as well. Agencies that have worked with QIOs back in the 7th and 8th scope of work were very much used to creating quality improvement plans. If you have agencies that are certified through credentialing agencies, you probably are already doing those plans. So that may not be new for you. But the majority of home health agencies, small, medium, and large, have sometimes left their quality improvement slip because there was not someone helping to support them like the QIOs in the past. Or having an expert, or change in staff, which is constantly occurring in QI departments. So with the QINs and QIOs, they're going to be able to help and provide more assistance on developing quality improvement plans. Now, as Cindy said, a lot of the states are limited with that, but the good news is that we continue at HHQI to be able to help and work with agencies related to quality improvement, and that can, if they don't make the cut or they don't get signed up in time, we're going to be able to help them with that. But I think the COP just ties totally aligned with quality improvement, using data to measure it and to validate your improvement and to sustain it. So I think you have great valuable resources with your QIN QIOs as well as with HHQI in helping you to meet those regulations. And I know they're proposed, but the basis is there and the writing's on the wall that you really should jump in and get started now for those easy things. And then the other pieces you can continue to work out as the details come out. And that would be my personal recommendation and comments.
Great. Thanks, Misty. I'm wondering, Cindy, if you have anything else that you'd like to add.
No, I think Misty summed it up very nicely. It's just encouraging everyone to look at the COP and take it seriously, even though it's not finalized at this point. But do look at where home health is being taken and make sure that if there's anything that we can do, we want to help. So thank you for that chance, Teresa. We appreciate it.
Great, great. So we've gotten a few questions from our listeners and watchers on the webinar. And this first question comes from Connie Meow. And she asks here whether or not HHQI has considered developing a BPIP for optimal staffing to produce best outcomes. And I guess she's thinking in particular about the fact that NHPCO has developed some some great staffing guides or resources for hospice providers. And there aren't a lot of resources for home health, but it's a really significant issue. And, the challenge, of course, is trying to, optimize staffing and benchmark productivity. So anyway, I'm wondering if you guys might be able to speak to that, because I think that this is, she raised a really interesting question, and I think one that I think Alliance members are thinking about a great deal, in terms of how do we really optimize the members of the home health interdisciplinary team, and, particularly in the midst of, times where finances can be strained because of payment constraints, right? So I'm wondering what you guys are thinking about that.
Well, this is Misty. I'll throw.
I was
I'm
just saying
sorry.
I didn't want to talk over you, and so okay.
And I was waiting for you as well. Sorry. I'll throw my 2 cents in. In our constraints of our fourth phase, we're really geared. Right now we're focusing this first year on cardiovascular health. We are already deemed then the following years to be working on other disease types, things such as COPD, falls, a lot of those type of packages, depression, the chronic disease and the chronic depression that we see that goes along with those. But this is a topic that we have addressed and continue to address. We don't have the answers, but what we do is in our underserved population networking calls, and even we talk about, because you have staffing issues in rural situations where you cannot get a therapist or a social worker for, you can't even knit one, is what they usually say. And you also see very similar issues in the urban setting, but for different reasons. So we have addressed some of those, or at least had brainstorming. We don't anticipate at this time to really be doing a BPIP, but that is an excellent question. That what we can do is make sure that we can gather as much resources and open dialogue up, either through an underserved population call or through another avenue within our structure to, again, try to come up with a lot of other suggestions. That's what we've done on some of our sharing calls in the past with the underserved. So that's my 2 cents.
And this is Cindy. I'll just throw in that I know over the summer, staffing issues, that's a very large topic, kind of the same as I want to reduce avoidable hospitalizations. It's equivalent to I want to create world peace. It's a very broad topic, but when you focus in on what specifics, there are multiple studies that are going on right now. And I don't know if they're completed, but over the summer, I think there were 4 different sites that were working on front loading to kind of come up with at least some guidelines and understanding of what is recommended for front loading and what is recommended for each specific disease process. And of course, there'll be some variations, but even some simple guidelines with what is considered appropriate front loading, because I think if you poll 15 different agencies, you'll probably hear 3 to 4 different ideas of the definition of the word front loading. But what Misty said is that, yes, we will continue, even though it won't be as a best practice package, at any point in time when the research comes through, we really enjoy having the ability to highlight it either through blogging or implementing it through the best practice packages. But one specific to that, probably not. But thank you. That is a really good idea to make sure that we keep that on the focus and on the radar.
And this is Misty. I did forget, I'm not going to go into details so we can get more questions, but we are going to be doing a lot of inclusion of care coordination and using your therapist and your aides to really minimize the number of visits to maximize the care that you're providing, and also in telehealth and how to adapt that more. So those are things that are on our earmark to do and be inclusive of, and that would also help. That's all, Teresa.
That's great. And I think that there's also, and I do think this is one of the big questions that I think the home health community and maybe more specifically Alliance members have been, really thinking about a great deal. As we think about, how do we prepare ourselves for the future of home health care, right? So we've, I think we've done a lot of discussion among Alliance members of what's that future strategic construct for the future of home health care. We've got an entire project that we're running around developing a strategic construct for the future. And one of the big pieces I think that we're going to try to focus in on is, some of what you touched upon, and it definitely goes to Connie's question, this question of how do we optimize and prepare the home health workforce for the future. And certainly that goes to training. And I know a lot of what you guys have talked about today actually goes to sort of education and training. But I think it also goes to this sort of question of how do we do more, and how do we optimize the workforce that we have, given that we're anticipating many, many more seniors who might be needing home health care just because of the demographic trends in this country. And how do we really optimize the technology? To your point, telehealth is one, but maybe, we're also talking about mobile technologies and point-of-care diagnostics and the like, so that we're really able to, optimally serve patients at home, and really support the ability to serve them both in post-acute care and in chronic conditions, sort of preventive maintenance sort of functions. So I think it's something that we're definitely going to focus on, and we've got a symposium on January 13th in Washington, D.C. on tackling critical issues for the future of home and community-based care, and this is going to be one of the topics that we will plan on focusing in on. So I hope that many of you on the phone will consider registering for that symposium. And if you're on this call, I hope but you're somehow not on our distribution list for the Alliance, I hope that you'll check out the Alliance's website and register on our public distribution list so that you can get information about the upcoming symposium, and feel free to reach out to me or to my special assistant, Jennifer Schiller, about that. So we've got one more question already here in the queue that I want to make sure we get to. This one comes from Salim Binderwala. And Salim has on his mind this trend towards accountable care. And of course, ACOs, accountable care organizations, are a type of organization that I think that many home health agencies are starting to either work with or might already be a part of. But certainly sort of accountability in care is a more broad theme, even beyond ACOs. And so the question that he had is, to what extent HHQI is developing resources or supports or education that will help to bolster home health agencies as we go through this trend towards accountable care. And I'm not sure if it's something that you guys have thought about very much, but I think it's a good question, and it's maybe one that sort of brings together sort of this question of how do we navigate healthcare delivery system reform, and what does it translate to in practice on the ground running?
Well, this is Cindy. I'll start and then toss it over to Misty. And accountable care organizations, for those of you that aren't familiar with them, are basically groups of providers coming together. It's usually invitation only, and usually serving a certain community of patient population. And what accountable care organizations have proven to be so far, there's multiple different formats taking place throughout the country. So it will differ from not just state to state, but it may differ from part of a city to another part of a city. But as far as home health agencies being integral in ACOs, or accountable care organizations, it's vital. I think it's vital that agencies get the information out there to their accountable care organizations and not wait for an invitation, just at least let them know what they are doing and what the agency is able to provide above and beyond, different from the actual standard fee-for-service type of information and type of care that we provide. And there are many agencies around the country, especially there's one in, I didn't hear the name of who you said sent this in, but there is an agency in Detroit that is doing phenomenal work with their ACO, and they are a small organization that did not start with being part of a hospital system. They were a standalone organization, and they were struggling because of it is not a certificate of need state. Michigan is not. So if you're a part of that state or part of any state that is not a certificate of need, it's very much a fight to get in and to work with your organizations. What they were able to do was show not only the quality of care that they provide, they were able to display the types of reduction in hospitalization they were able to provide, which is also a reduction in payment for the ACOs. And by doing this and utilizing the different tools and resources and showcasing what they're able to do, they actually not only got invited to one ACO, but they've been invited to multiple ACOs. And this will help with not only the patient population and keeping the patients out of the hospital, it also helps the survival of the agency itself. As far as what HHQI is doing to support that, and I just realized we're at the top of the hour, so I'll go really fast. Utilizing the tools and resources through the HHQI site will help not only further your cause in going through the ACO application process and getting in the door, but it will also help solidify the community of providers that are providing care to the set number of patients. And because we are at the top of the hour, I'll just say that if anyone out there is interested in this, please feel free to contact us. We'd like to have a further discussion with you and help you in any way that we can to support your endeavor into getting into the ACOs and working with providing improved quality of care in the home health patient. So, Teresa, I'll stop at that. I apologize for going long. I didn't see the top of the hour.
No, not at all. And I actually was just going to say that I wonder if some of the, because you talked about the data reports, I wonder if some of the data reports that you guys, as part of HHQI that you're developing, between that and then maybe also some of the cardiovascular data registry data, whether some of that information could be useful as you're trying to develop relationships with organizations, whether they're hospitals or physician groups or hybrid organizations of both, that are developing ACOs or other types of value-based arrangements.
Actually, that was the direction I was going to go before I saw the top of the hour, because the cardiovascular reports, the HHCDR, the registry that we talked about earlier, those are actually what we call PQRS measures. I'm not going to bore you with more names, but let me just say that that's the exact same measures that physicians' offices in this country who receive payment from Medicare are held accountable for. So these are the same measures that they're held accountable. Let's be clear, home health agencies are not, but it is a great talking point to utilize to reach out to the providers and let them know that you are working on the same exact PQRS measures, because the physicians are held responsible for these. So it's logical to think the physicians are going to be looking for agencies who are utilizing and are implementing interventions to help their patients meet these measures and these outcomes. So we found out during the pilot phase last year from agencies who were reaching out to their physicians, and maybe it was because the patient wasn't on aspirin and they needed to clarify, was the patient supposed to be on aspirin? That was a new question for the physician, not from his or her practice, but coming from a home health agency. It's like, well, actually, no, they're not supposed to be on aspirin, but why are you asking? That gave the agency the opportunity to say, well, we're implementing and looking into the ABCSs and implementing cardiovascular care. And the physician kept the nurse on the phone for another 10 minutes talking about this, and his excitement led to more referrals, because this was just classic of what this physician was looking for in helping the patients meet these measures outside of his office. So, yeah, the cardiovascular data reports as well as all the HHQI data reports are really good talking points. But remember, this data is treated the same as we treat patient information. It's very secure because it is raw data. So remember, no one's going to see these reports or any piece of this data unless you give them permission. So it's your choice. This is not publicly reported.
Okay, great. Yeah, it sounds like it's a really great opportunity to not just as a talking point to show that you're aligned, but to actually be aligned, right, with all of the physicians and hospitals, other parts of the healthcare system that are all trying to achieve these particular measures, and I think it's sort of incumbent upon, all of us to also bear in mind that, okay, those are the measures that, the Medicare program says are important, and we know that they're sort of, objectively considered important for cardiovascular health. And then to also balance that with sort of patient-centeredness, really getting back to what are those patient-centered goals. So I think there's always more to be done, and it's amazing the work that you guys are doing, because I think that it makes a difference in every corner of the home health community. So thank you guys. I think we are at beyond the top of the hour now, so I'm going to suggest that we conclude, but I'll just point out that the slides from Cindy and Misty's presentation will be on the Alliance's website. If you can give us maybe 10 to 15 minutes to get it up, they will be posted shortly. We have been recording this webinar. We will also post the video playback of the webinar as well as soon as it's available. So stay tuned. And again, if you have further questions, would like to follow up with Cindy or Misty, you can certainly reach out to us at the Alliance, or you can check out their website. And we look forward to having you on future Alliance webinars. So thank you again, Misty and Cindy, and I hope everybody has a wonderful afternoon.